technical issues, but as David kindly introduced me, my name is Henry Chicaiza. I work at Connecticut Children's, which is located in Connecticut, United States, in the Northeast. We're a tertiary hospital seeing about over 60,000 patients a year in our emergency department. There I serve as the emergency ultrasound director here. I'm also the founder of PPAC, which is a teleconference that happens on Thursdays, as David alluded to, that I started during COVID, just because, as you guys all remember, we couldn't touch any patients. We couldn't have any bedside education at the time. So then I decided to do a teleconference where we address advanced POCUS at that time. So that's what we do. We've been running around for 4 years. It's been very successful. I've been lucky to find a lot of people like David from international wise. It's been a fantastic collaboration that if you guys are interested, just feel free to email me and then I can give you the link. It happens on Thursdays at 1 p.m. our time. And I think he said it was around 6 p.m. for you guys over there. I also serve as a co-chair of education at the P2 network, which is the P2 network. If you guys are not, if you haven't known about it, is essentially an organization of POCUS experts that come together and basically we discuss anything about term POCUS. We try to instill education, work with regulations, and sort of distill the knowledge. As an international organization as well that you can sign up to. And then currently we're going to actually do our annual conference in March in Boston this year. So that's something also that if you're interested in joining, you have a great website, which currently is down right now. So otherwise I would tell you to give you the link for the P2 network link, but unfortunately right now it's going some changes. So, but that's something else that you guys can participate and we'll welcome it. And then we always have great collaboration there. So. But without further ado, so I'll start with a case, as all really good POCUS lectures start with. So this case is a 10-year-old with no significant past medical history who presents with sore throat and inability to open his mouth. Review of systems, he's found to be febrile and having decreased PO intake. His vital signs are currently stable, no fevers. He was given Tylenol Motrin right before coming in by the mom. On your exam, he has limited exam due to pain. He barely opens his mouth. He's not cooperative. The resident who comes in and evaluates him thinks maybe a peritonsillar abscess because he's unable to open his mouth, but he's not sure because he's unable to do sort of like a physical exam on him. So, so that's sort of the conundrum what's going to lead into this talk. So the main talk that, as the title alludes to, is essentially using POCUS for the identification of retropharyngeal abscess and peritonsillar abscess. And in this case, those are the kind of two things that are sort of like diagnosis to consider in this patient, and then with a patient that's unable to open his mouth, and that's where POCUS comes in very helpful at this time. So just to give you a quick sort of a background in terms of what we're discussing. So the first thing we're going to discuss about is peritonsillar abscess. So peritonsillar abscess is the most common deep neck infection in children and adolescents. It accounts for approximately 50% of all the cases and occurs more frequently in adolescents and young adults, but also in younger children. So usually we think these on adolescents, that's where in terms of like what the population that we're looking for. Sort of the anatomy, I hope you guys can see my cursor in terms of where it actually happens. So you're going to have the peritonsillar abscess right at this dotted line, which if we cut right through horizontally, this is kind of where we get. And this is a peritonsillar space right here. That is the space where you're going to have a seeding infection. So here's your tonsil. Usually it gets infected, secondary to usually like strep. And then basically right there, there's this space that the infection can seed in and create inflammation and a fluid collection. In terms of microbiology, so the predominant bacterial species is strep pyogenes, group A strep, as I said in the previous slide. We also have other types of streps and staph, including MRSA as well, and the respiratory anaerobes that we're accustomed to seeing, especially now. So the typical presentation for peritonsillar abscess is a severe sore throat, a hot potato or muffled voice, trismus, that's related to irritation or reflex spasm of internal pterygoid muscle and occurs in approximately 2/3 of the patients. And some even may have ipsilateral ear pain. So that's something to take in consideration as well. So this is sort of like the classic peritonsillar abscess, where you see that there's an inflammation in the soft palate, and that creates mass effect and pushes the uvula to the opposite side. But for these are sort of like, if you see this, you don't really know ultrasound. So you just see this, you go, oh God, that needs to be drained. You may need ultrasound to help you guide the drainage, but you don't need ultrasound to help you diagnose it. So these are the ones that are sort of like very like straightforward. You're like, okay, there's a peritonsillar abscess. If you're going to use POCUS, it's probably to direct your drainage, but it's not going to be, it doesn't add anything to the presentation. The problem is that there is diagnostic challenges in the pediatric population, or even in the adults. There's the trismus that we were talking about, or they're not going to be able to open their mouth. So you're not going to be able to make that determination. And a physical exam has been proven in the literature to be often unreliable. The sensitivity and specificity has ranged from sensitivity has been about 78%, and the specificity has been 50%, which is kind of lousy. Like it's like you throw a coin and you get a 50% chance, and turns out sort of like your clinical diagnosis of peritonsillar abscess. And the other problem is it's difficult to distinguish between the peritonsillar abscess and other deep neck tissues, deep neck space infections, just like peritonsillitis and also like retropharyngeal abscess as well, just because it's hard at that time, especially if you're unable to get a good physical exam. So that is where POCUS comes in play here. So POCUS has been increasingly been used as an adjunct for the diagnosis of peritonsillar abscess. The sensitivity, it ranges based on the literature from 89 to 95%. The specificity is from 78 to 100%. So that's really good. So, and in the hands of the right person, basically, you can easily diagnose peritonsillar abscess with ultrasound. However, there's two techniques, and sort of like the traditional technique, which is an intraoral, using intraoral probe, but then there's also sort of like it's not as novel anymore, but still people are not as familiar with it, is the transcervical approach, which I'm going to talk about both of these approaches in this talk. So first, we're going to start with sort of the traditional one, which is the intraoral, and you have two probes that you can use for this, which is the we don't want to call this the endocavitary roll or the vaginal probe, so I use for endocavitary probe that you would use, but also you can also use the hockey stick, the probe. These are become excessively small, depending on which ones you get, but then that one has been more commonly used as it's smaller than the endocavitary probe. So those are the two probes that you can use for this. And as David said, if you have any questions on any point, just raise your hand, interrupt me into insurance if I'm going too fast, or if you have some questions in between. So first, we're going to start with the endocavitary probe. That's basically the only probe I use. I don't have a hockey stick, but I wanted to sort of give you that perspective in case you have a hockey stick in your facility, and you can use it as well. So with the pointer down on the probe, essentially, this is still, I'm going to go through videos, obviously, but just to get a better orientation, essentially, you're going to have the mouth, which is kind of here, which is kind of hard to tell. And then you're going to see the tonsil here. And then posterior to that, you're going to see right here, you're going to see the carotid artery. So that's sort of like your anatomical landmarks that you're going to use. And if you're sort of comfortable with soft tissue ultrasound in terms of like diagnosing cellulitis or abscess, this is right in your wheelhouse, because essentially you're making contact right with the area of inflammation and sort of looking for an abscess. So if you have very comfortable diagnosing cellulitis or abscess using the linear probe, this is kind of an extension to that and should be pretty adaptable for use as well. So the cum still, so I'm going to tell you that this is kind of like, it's going to be pretty easy for you guys to determine, sort of like looking at in terms of what you see in. So probe is there, and then here you have your tonsil. It's So, and here I'm actually, this patient allowed me to put pressure on this, on his on the area of inflammation, and you can see sort of the the swirl sign that we always look for abscess. We always see all that pus swirling around in there. And in this case, you have kind of more of an echoic area. You don't see the swirl sign on this patient, but you can clearly see that it is an abscess collection there. And posterior to that is your carotid artery, which is important as a landmark because essentially, if you want to drain this this abscess, and depending where you work, in our facility, I'm very spoiled. Our specialists, so our ear, nose, and throat specialists will come and drain this for us. But there are other institutions, especially if there's adult docs that are on the call right now, is you guys do usually, like us here, my doc colleagues are usually do the drainage themselves. So this actually helps you guide in terms of how you drain it. Because one, you get a good sense of how deep this this abscess is, so you can actually measure sort of how long it's going to take from the skin all the way to the abscess, and then you can correlate and easily put sort of like either a cap on your needle, or the other things that they put is you can put tape around your scalpel so that basically you don't go past that point, and because you don't want to hit this carotid artery, because that's kind of the major thing that might happen in terms of that. So so these are sort of like, that's why ultrasound is very important, very useful for the diagnosis of peritonsillar abscess. So I'm going to go through other images, but these are kind of the sort of like in your face, very easy to diagnose, very easy to see. So and I'm seeing the chat there. So in terms of what makes it a distinctive for abscess, so on the left side, so, and I'm going to show you a picture of just what the tonsil looks like but here you see an anechoic, so essentially black area, and within a contained area, which is distinctive of an abscess. Because a tonsil is going to look more heterogeneous, is going to have kind of the ridges that you will see. On the right-hand side, you see it more distinctive just because, as I swear, one of the things that is sort of like the typical sign for an abscess is a swirl sign, which is where you see it right in that area, which is when you push on it and you see the movement of the fluid within that capsule, and that's basically a distinctive for abscess. So, and so those are the features that makes it distinctive for abscess for the person that was asking for it in the chat. So this is just a more unique clip, so that way you guys can see it in a full live. So again, very helpful to kind of help you see where you're going to need to go. And then you can decide either to do the drainage either right with the probe there, which is kind of hard to do because I used to do it back when I was a fellow, using the probe and the needle at the same time. And, you know, it's probably a lot of people, if you have done it, there's kind of limited space to do all of that at the time. So you can either sort of landmark it or just try to do it in another way, which I will discuss in a little later. This is another example of a teenager that came in with sore throat. These are all very like patients that were able to open their mouths and allow me to, you know, to put the probe into the area of swelling, which can be very tender when you do it. So one of the things that some people do recommend is if you have some lidocaine spray, which is what the ENT folks use, which is one of the things that they taught me, is like they carry around this little spray that has a little gadget that basically you can just like put it right in the tonsil area where you're going to do, and that's how they numb it. The other thing you can do is you can just take lidocaine jelly, put it on a on a cotton swab or anything, and just put it right in the area where you're going to go, because like I said, just like any abscess or any swelling, this could be really painful for the patient to, when you're doing examination, and then it could be very like hard to get these images and as clear as they are right now. But we come to the conundrum. The 10-year-old back in our case that refuses to open his mouth, is unable to do it, which is a common problem in pediatrics. So, what you do with that patient. So that's where the transcutaneous approach comes into play. So this is where we use a linear probe, which is a probe that you usually use for cellulitis or abscess, and you put it right underneath the mandible at a 45-degree angle. Your probe, which is, your indicator, which is right here, it's towards the ear, and that's sort of like how you do the technique. It is painless. It doesn't hurt whatsoever. You just turn them to look to one side and just apply the probe into that area. Now this one is a little more hard to sort of like kind of like put in like the image inside your head. So it takes a little more practice. So I would always advise you that if you have a patient that has a peritonsillar abscess, that you do it with an intraoral device, and it's like blatant, just like the ones I showed you in the previous images, to do this technique on that one. So that way you can sort of see what your like the anatomy and what does an abscess look like, so you can get comfortable with it, because this is kind of like sort of hard to explain at times, and it's more like a visual like challenge when you're trying to like orient yourself as to where you are. So, but when you prove the probe right underneath the mandible, what you want to look for is the tonsil, which is going to be right in the center, the internal carotid, the submandibular gland, and you're going to see your tongue there. So that's sort of like going to be your anatomical landmarks that you're going to use. And then I'm going to go through sort of like videos now. So again, so you put the linear probe right at the mandible at a 45-degree angle with the indicator pointed towards the ear. And what you want to look for is, you see the submandibular gland, the carotid right here, and then you have this tonsil, and you have the tongue here. And then, like I said, in this case, we're using the sort of like small footprint for the linear probe. So you can't see the whole thing, because I actually use the tongue to sort of tell me where I'm going, because you can tell the patient, hey, can you move your tongue? And you can see it move on the screen. And then what you're going to end up seeing is kind of this view right here. So right in the center is your tonsil. And what you want to do there is sort of like move your probes very slightly up and down, basically fanning through. And then you're going to be able to see if there is an anechoic space, aka black, in the area near the tonsil that's going to be indicative of a peritonsillar abscess. So here you see a heterogeneous area here, circular area, which is consistent with the tonsil. But right over it, you see this area here that's anechoic, and that's indicative of an abscess, or peritonsillar abscess in this case. And I'm just going to take it. Yep. Okay. Yep. So yes, definitely. A lot of people use this to look for just lymph nodes, which actually in this one, I forgot to point out, you see a lymph node right in this area. And usually we use it at a right at a 90-degree angle. In order for you to visualize the tonsil, all you have to do is go at a 45-degree angle, like go encephalat, and that's how you're going to be able to see the the tonsil at that time as well. You might have to go a little deeper. So this one was set at 4 centimeters. And depending on the adult, you can actually may have to go a little deeper for that. Here's another example where you see the submandibular gland, which is going to be it's going to be kind of the first thing you see, the anterior. And then here you're actually able to see the tongue, which is right here, which is striator muscle that you can actually, for adults, you can actually say, hey, can you move your tongue? And then this is, he's actually doing right now. This, I think he was an 18-year-old that did this for us. And he was moving his tongue so that way you can see this movement right in this area, right here in the right side of the screen. And that's saying, well, that's his tongue. So then the tonsil is going to be right posterior to that, which is right in this area here. And you've gone too far, because your other landmark is going to be your carotid, which is going to be right in this area here. And you can use Doppler to show you. So the tonsil is going to be sandwiched in between the tongue and the carotid. So that's going to be sort of your landmarks and how you're able to identify your tonsil. And then, as I said, you have to fan through so you can see if there is an anechoic area that is going to be consistent with a peritonsillar abscess, just like we're seeing right in this area right here. If you don't fan, you might miss an abscess collection if you're not fanning slowly. So, and as I said, this is not painful. So if the patient just holding still, it's easy for you to fan through and be able to identify if there's a peritonsillar abscess or if it's just a big tonsil that's indicative of just cellulitis. So the measuring has been sort of like debated. Like I said, this is a very novel use, and I'll get to the terms of like the conundrums here. You can measure it at its biggest width. That's kind of the main thing. And it's sort of like ripe for research because no one has like sort of seen like, well, you know, how big does it have to be before we drain it? You know, I do my best sort of like guess in terms of that. I kind of use the same as literature for other abscess, which is less than a centimeter. I'm not going to drain it. I'm going to probably start antibiotics and go from there. So you try to look for the biggest pocket, and that's where you measure. So in this case, I would measure. I'm going to pen. So I would measure kind of from the biggest space from here to here and see how big is that. And then kind of make my best guess along with the clinical exam whether it's going to be worth doing a drainage, and taking consideration that if this patient was unable to move to open his mouth for you to do the endocavitary probe exam, or even just to look at with your clinical presentation, they're not going to be able to open their mouth for a drainage. They're probably going to have to be taken to the operating room in order for them to do that. So. So this is very helpful in determining whether or not, you know, if it's a big pocket, then yeah, but if there's a small pocket, I have my experience with this. I start them on antibiotic here. We usually use clindamycin, and then I do follow-up. And so far, none of those patients have come back with a bigger abscess. So, and I use like the 1 centimeter rule, and then that's kind of like been my sort of my practice here in my hospital. For patients that are bigger, especially for the adult populations, I know that there's some adult colleagues here. You can actually use the curvilinear probe to diagnose a peritonsillar abscess, or to even sort of like when I training our fellows here, I tend to use this one to show them the landmarks because you can actually see everything in one slide. So in this slide, you're seeing the tonsil right in the middle, because again, your anatomical landmark is going to be your carotid, which you see it nice and pulsating right here. And then you're going to see your tongue right here. And then your submandibular gland is right there. And there's a lymph node right in this area. And again, you see in sort of like your tonsil right there, but then you see anechoic areas around it, which are indicative of a peritonsillar abscess. Unfortunately, as you guys know, the curvilinear probe is not going to give you the nice little detail that you're accustomed to it, unless you have a very advanced ultrasound machine where you can change the frequency and increase the frequency, which is, you know, our radiology colleagues do have those type of capabilities, but and then you're not going to get the crisp views, just like I showed you in the previous one. So I kind of use this for more teaching purposes in terms of showing fellows like the anatomical landmarks, how everything looks, and then switch to the curvilinear probe to see the very crisp images of the area that we're interested in. Just to get more accustomed to it. So these are another view of a peritonsillar abscess. So again, because it's kind of deeper, we aren't able to get sort of your anatomical landmarks. But you have to trust me in that to the right of the screen was your tongue, and here posterior to it was going to be your carotid. And what we're looking for is this area right here, which is your tonsil, but then you have this anechoic space right here that's consistent with a peritonsillar abscess. And all these were confirmed with endocavitary probe. So then, like I said, whenever I have a chance to teach and I have a very obvious peritonsillar abscess, even on clinical exam, that's when I use this transcutaneous approach to teach. So that way the fellows can look and see what it looks like on the ultrasound. So that way when they have a tough case where they're just basically just relying on the POCUS to make the diagnosis. They're ready for it and they're very accustomed to it. So. So now what I'm going to do is I'm going to put side by side in terms of patients that presented to the ED with concern for peritonsillar abscess, where they actually let us use both the endocavitary probe and the transcutaneous approach. And that's what it kind of did for teaching. So in this right here on the left side, you're going to have the endocavitary probe that's looking at the abscess. Here you see the tonsil, but right as you're finding through, you see this anechoic area in the middle here, which is consistent for an abscess. And on the right side of the screen, you see in the transcutaneous approach, and here, this was the slide that I was showing before. You see the tongue is right here, your tonsil is right in there, but here you see this anechoic area, which is consistent with this abscess that's located on the left side of your screen. And this was something that needed to be trained because, as you can tell, this is probably like around 2 centimeters. So it's a big collection here. And then you're able to, we call our specialists here, the ENT folks, they came in, they trained it, and they started the patient on antibiotics. Kind of another example where we're seeing here. So on the left side of the screen, you see the endocavitary approach. And this one, you see that the collection is a little smaller. So I wanted to give you a sense that not all of them are like distinctive as the ones I show you right at the beginning of this presentation. But you're seeing kind of this little fluid collection right here, which is around 1 centimeter, another one right here. And when we use a transcutaneous approach here, where you see in, the carotid right here, and you see in your tonsil there, you see this anechoic area as you're fanning right in this area right there. That's consistent with that. Because they were kind of connected, because as you can see here, ENT did come by, did train, and trained a lot. So it was another helpful diagnosis by that as well. And then we have this one I use kind of for teaching, is where I use the endocavitary, but I use a different approach here just to show. And I wanted to show you how when you use the curvilinear probe, that you don't get all the crisp images to make a diagnosis. Because here, using the endocavitary probe, you see very distinctive that you see an anechoic collection right here, which is consistent with a peritonsillar abscess. And then when we use the the curvilinear probe, you see the tonsil right here, carotid, tongue, but you can't really make out like sort of like a big area of abscess. Maybe like right in this area at the end of the clip, but it's not very. You're not able to make that big transition. You would expect with this big abscess that you should be able to see a big fluid collection on the transcutaneous probe. And that's sort of like my hesitation to use a curvilinear probe. And I always switch over to the linear probes because I can get very more detail, because as you guys would know, the linear probe is higher frequency, so it allows me to have a very detailed, whether the curvilinear probe has lower frequency and allows you to get deeper, but you lose kind of sort of the crisp, the bright images that will allow you to make a better diagnosis. So now we're gonna, unless there's any other questions, I'm gonna switch gears to the next sort of like the retropharyngeal abscess. So we have a 3-year-old that came from an outside hospital that had 2 days of fever, fussiness, and neck stiffness. Had associated headache and neck pain for 1 day. And then on the day that he presented to the outside hospital, also developed a fever. There was no cough, no vomiting, no diarrhea or rash. And just quickly, Nina, I'll get to that right in a second. So, but you can use both approaches actually. So you use the intraoral probe, but you can actually use the transcutaneous approach. It's a little more sort of like an advanced technique, but you can actually use it where you put the probe right in here and use the needle, and you actually will see the needle with that approach. So you can do both ways, but I said the intraoral is kind of like more straightforward because you're seeing where the inflammation is, the swelling, you put the needle right in there. Whether this is more an advanced technique because now you're kind of going in sort of, you're going to go towards the area where you there's the most amount of swelling, putting your needle through and then visualizing it in the transcutaneous way. But that's more of an advanced method, which here, you know, there's only very few people that have done that. So back to the case. So we have, you know, the kid came over to us for our ED. Vital signs were temperature was 99, pulse was high at 133, respirations were 32, blood pressure was fine. He appeared tired. He was tender in the right side of his neck. There's minimal swelling there. There was no erythema, but he had a limited range of motion. So at the other hospital, they got soft tissue or neck X-ray. And for those that you're, you know, that for retropharyngeal abscess, you can use the neck X-ray to help you with the diagnosis because you want to see this area right here where you see in my screen, the retropharyngeal area swelling. And the way you can tell that it's swelling is if it's more than half of the vertebra. So if you take this vertebra here, cut it in half, if this area, retropharyngeal area, is bigger than that, then by definition, there is suspicion for retropharyngeal abscess. However, there's limitations to this X-ray. Patients should be hyperextended because if they're like, unfortunately, in the 2-year-olds, they kind of hold their necks like this. It can actually fool the X-ray and make it seem like this area is thickened, and then they cannot rule out a retropharyngeal abscess. So I'm very careful when to use the X-ray, and then I'll get to that in a little bit in the later slides. But the referring hospital got this, so this was concerned for retropharyngeal abscess, and they shipped them over to us for further evaluation. So again, to give you a sort of quick overview on retropharyngeal abscess occurs more commonly in ages between 2 and 4 years of age. The examination, when they did a database here of the United States between 2000 and 2012, there's been an increasing amount of retropharyngeal abscess cases that we've been seeing as well. There's been nothing currently, but that was the last time, so it was surveyed. So the retropharyngeal space contains 2 chains of lymph nodes that are prominent in the young child, but as anything in like the thymus for in children, it disappears by the age of puberty. So that's why it's just less likely for you to have a retropharyngeal abscess, after when you're a teenager. Granted, I've seen one in a teenager, but it's really not common at all. Approximately 1/4 of the cases that happen in the older population, the infection is be secondary to some type of trauma, like a penetrating foreign body, an endoscopy, and intubation, or dental procedures. So, in terms of the microbiology, so it's a polymicrobial infection, but the predominant bacterial species is strep again, Staph aureus, MRSA again, and respiratory anaerobe. So similar to that of peritonsillar abscess. Clinical presentation depends on the stage of illness. Early in the disease, it's really hard to distinguish it from just like pharyngitis. And children with retropharyngeal abscess generally appear ill and moderate fever. That's not necessarily true with this. That's sort of the classic presentation. And other things is dysphagia, odynophagia, dysphonia, drooling, neck stiffness, and trismus. So those are sort of your classical presenting signs. Yes, yeah, we'll get to the sort of the X-ray. Yeah, so I don't use X-ray to help you with this. So plain radiographs are often used as a screening test in a stable patient. As I told you, for proper precision of the lateral neck is vital to avoid false positive results, and the sensitivity is 80 to 83%. So I don't really rely on this on radiographs. I don't get them actually if I'm concerned for retropharyngeal abscess because your sensitivity is 80%, so 1 in 5 kids you can actually miss one. So that doesn't bode well with me, especially with such a it can have a lot of complications. It can get sick really, really fast. So I don't depend on plain radiographs. But if you kind of see, that's kind of the first thing that people use. But that's sort of what got me interested in this area. And working with one of my previous fellows and one of my ultrasound mentors here, Dr. Adam Sivitz and Lori, we did a case series of using an approach to diagnose retropharyngeal abscess using point-of-care ultrasound. We published it about now, it's going to be 3 years ago now. So the neat thing about this is that if you already have experience using it, using the transcutaneous approach to diagnose peritonsillar abscess, you actually can do the similar approach to diagnose a retropharyngeal abscess. The only difference is as I told you, for peritonsillar abscess, you do at a 45-degree angle. For these, you want to go up 90 degrees because you're looking straight for the vertebrae. And on the still image, and I'll obviously give you videos, but what we're going to look for is the vertebral body that's going to look like kind of a stepping stone. And you know that's the vertebral body because it's basically very white, and then creates shadowing, and that's your vertebral body. And then you're going to see your vessels right here, and your potential space is your retropharyngeal space, which is anterior to the vertebral body. That's where the area of the retropharyngeal abscess is going to be. So this is sort of what you're going to be seeing. So here you see the vertebral body. Again, you see this very white line causing the shadow underneath, and you see your vessels here, your carotid and jugular. And here you're seeing this fluid collection. And just to give you a reference here, this was on the right side of the body. When we went onto the left side here, you see the vertebral body here, you see your vessels here, and you just see kind of like regular like fascia here. You don't see. The other thing that we also noticed was that the space between the vessels, because of the inflammation, increases here. As you can see here, there's kind of, everything looks kind of nice, and you can appreciate all the anatomy real well. Here, everything's distorted because now you have this fluid collection, this swelling, and it's causing like this, pushing out the space between the vessels apart, and that's one of the other signs that we describe in our paper as well. This is sort of another patient with a very obvious retropharyngeal abscess. Again, vertebral body, the retropharyngeal space, and then here you see a fluid collection as well, right in this area. Compared to the opposite side, and that's what's great about this technique is that I'd never seen this, but I'd never seen a bilateral retropharyngeal abscess. So you always have a normal side to compare to, which is great because you're able to see in this kid, again, you see the vertebral body and you see everything is just nice. You see all the vessels, musculature, vertebral body. And then when you go to the other side, you see all this inflammation, and then it's fluid collection that's consistent with a retropharyngeal abscess. Give you a couple other cases that that we've seen. So again, vertebral body here, and then you see this area here. This was actually a phlegmon. Since my radiology folks know who I am, I actually thought that I was like, am I missing something? What's going on here with this area, right, that you see in here? And I went over discussed my images with our radiologist, and he used actually ultrasound because eventually this kid got a CT, but he actually relied more on my ultrasound images to determine that it was a phlegmon, not abscess. So that was kind of great to see. So you can see this area right here. So it was not recommended for the patient to have a drainage by our specialist, and the kid did great just on antibiotic, IV antibiotics, which he was trained. So that was one of my cases where I built a very strong relationship with radiologists, and no radiologists do this. Everything, this is point of care ultrasound. So you'd be at the sort of front line sort of in terms of when you're using this. So the images, so here you have the vertebral body again, and here you see this fluid collection again, anechoic black. And then unfortunately, you don't always see the space between the vessels like increase like other views. And then here you see the same patient, but again, you see the vertebral body, but you don't see anything occupying in this area. You just see regular musculature, you don't see this anechoic space in this area, and sort of like the inflammation signs surrounding that area. And this one just was another patient that I had recently. The left side is actually the healthier side. And this one here, you see the nice stepping stones with a vertebral body, your vessels here, musculature, fascia here, and then you compare it to the other side, and you see, as David says, badness here, and then you see the anechoic space, consistent with a abscess and the inflammation around it. What was interesting is that we presented this, got a good feedback, and one of our other colleagues, thanks to the PPAC meetings we had, he said that once he read our paper, he said, you know what I also wanted to see was that if I lay him down flat, and I'll give him Dave 10, he works at Cohen's Children's. He said, if I put the probe kind of right in that area where I can look at all the vertebra with the indicator towards the head, he was like, I actually am able to see the vertebra and the abscess anterior to that. So I have adopted that technique, and then what you see in here is your vertebra that's here, that the very white area with shadowing, and then you see all this inflammation, and you see the abscess right in this area right here. And you can actually potentially measure the abscess, because one of the things with the actual approach that I was showing you before, you're unable to kind of like get a sense of how big it is. But when you're doing it this way, you actually can measure this area right here. And that's what the surgeons want. They want the location and how big it is. I found this technique very, 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 very helpful. And unfortunately, we didn't think of it when we did our study or presented our case series. Definitely give Dave 10 the credit for, reading our paper and then adding his spin on it. And now that's the way I teach now. So I tell you to do the actual view, but then switch over if you see an abscess collection, put the patient in this positioning, and then flip your probe 90 degrees, and then look for your anatomical landmarks are going to be your vertebral bodies that are going to be at the bottom of the screen. Anterior to that, you're going to see obviously muscles. The muscles that are there, you're probably going to see some lymphadenopathy as well. But right in the middle there, you're going to see sort of the abscess collection right there. That's going to be anterior to the vertebral bodies in the retropharyngeal space. That's going to be consistent with an abscess. So back to the case that for that case was a 3-year-old that came from the outside hospital with a concern of retropharyngeal abscess. They did an extensive workup over there because they couldn't differentiate it from meningitis at the time. So impressive white blood count of 33, CRP was 5, ESR there. They actually did a lumbar puncture, which I was just impressed that they did that before sending them over to us. But this was a patient that when I immediately saw the X-ray, I put my probe on it, and then was a very clear retropharyngeal abscess that we can see on the screen right here. And then on the right side, it was the normal side. CT, I showed the abscess here that you can see here, and then obviously here. He was trained and basically did really well after that. So in summary, POCUS in the intraoral approach is a useful tool for diagnosis of PTA. It's been studied well. The transcutaneous approach for peritonsillar abscess needs to be validated. And the novel approach for the RPH also shows promising, but also needs to be validated. So these are areas for multi-center studies that if you guys are interested, please email me. I've always been on the hunt for doing this because of either doing both techniques or the retropharyngeal abscess is hard to do, and we need a multi-center for that since we see around like 8 to 10 a year in my institution. So you would need a lot of institutions to be scanning all at the same time to get sort of a good number of cases so we can validate the approach. So this is an area that I would love to do more work on. So if there's anyone there that's interested in doing this and doing more, feel free to email me. But that's pretty much it on my end. And then these are all my colleagues that we work at. We're having a lot of renovation in our hospital, building another tower, but I'm very lucky that I've trained a lot of fellows I have stayed. So I have multiplied myself. So there's 6 faculty here that can do ultrasound. And then we have a very robust fellowship in there. And then putting my P2 network hat on, we're having our annual conference in Boston. This happened March 14th and 15th. It's all about POCUS. So if you have interest in POCUS, it's a great organization to join. Right now, it's free to join, and you guys can come. It's a great time. We have colleagues from all over the world comes in Israel, Sweden. So definitely, if you guys, I'm hoping to meet David at one of these, hopefully one day that comes over. But we always have it. So feel welcome to come. And again, Nigel and David can share my email if you guys want to join PFAC or P2 Network. And sorry, I didn't leave as much time for questions.
That's all right. Firstly, any questions from anyone in the group? I know we've had a bit of chat in the group, and you've certainly taught me a lot. So thank you. I love learning new POCUS. If anyone has any questions, feel free to stick their hand up. I read your paper, Henry, and I knew you'd done a bit of this because of the PPEC stuff. And I must admit, even seeing the view initially, it did take a little while to wrap my head around it, but you've made the talk really, really clear. And this is definitely something I'm going to add in. One of our colleagues has got a question. I don't know if you want to field it.
All right.
I think it means false. Does it mean false positives? Question about if any positives you come across while reviewing training scans, false positives.
No, I have not yet. And like I said, it could be because we only see just so few of them. So that's why I want more people to get comfortable with it, and then hopefully do like a multi-center study to see if we're going to miss some.
Sounds good. Yeah, I know this is a presentation that can cause a lot of concern, can't it, with kids who are drooling, obstructed. I've started to have a little look for foreign body, which again, there's not a lot in the literature for POCUS for ingested foreign body, obstructed foreign body. And I think I've only had a couple of these clinically, but I'm definitely going to start and practice and do some more views. So I think it'll be really helpful.
Yep. And then feel free, like if you want to discuss any like images you got, you can always feel free to shoot me an email and then we can discuss. But yeah, this is one of the areas that I would like to get more research on. So then, like I said, anyone who has interest more, we can definitely work something together.
I keep telling these guys these guys are the future. We're the future. We've got to sort of change practice bit by bit. So yeah, it's good. Well, thanks again. I think that was excellent. It was a nice break from my high-level echo course that I'm on. So I'm going to get back to that. And as I say, we're meeting next month. Look out for the emails. It's going to be me doing some cases, and then we're going to have some of the other speakers from the US hopefully join us into March and April. If anyone wants to speak, please get in touch. You don't have to be an expert, just some cases you've seen, or even picking a literature review would be brilliant. So take care, everyone. Thanks again to Henry. Enjoy the rest of your day. Go and have your breakfast cereal, and see you later.
Thanks. All right. I look forward to seeing you.
Thanks.
See ya.
Thanks. Bye-bye. Thanks, everyone.